in the day than with our fantastic upcoming keynote speaker. But before I introduce him, I want to start with just a couple of reminders. So as you all know, this session is being recorded. It's going to be available on the conference platform just about an hour after the session ends. You all are muted because this is in webinar format, so you don't have to worry about that. Please feel free to drop your questions in the chat for Dr. Fagan. And just a reminder that we will be doing prize drawings for all the sessions that attendees attended live today. Another quick reminder before I turn it over to our keynote speaker, we are offering free continuing education credits today. For more information about that, please visit the continuing education page on the conference platform. And with that, I'm very excited to introduce Dr. Blake Fagan and his keynote session, an update on psychostimulant use disorder in the United States. Dr. Fagan, we are so thrilled you could be here with us this afternoon. And with that, I'm going to turn it over to you.
Great. Thanks, Lydia. Can you hear me okay?
We can hear you and we can see you.
And we can see the slides moving. All right, great.
Yep.
Well, welcome everyone. I hear that you've had a very long day, so I appreciate you hanging in there with me. And over this next hour, we're going to go over stimulant use disorder. But I wanted to set some ground rules. I would really appreciate it if you have questions to go ahead and put them in the chat. And we have several people monitoring the chat, and they know to just go ahead and interrupt me, and then I'll answer your question. So please, again, I want to take the questions as they come instead of waiting to the end. And then at the end, hopefully we'll end with just a few minutes and can take a few questions from the chat then as well. But again, please ask questions along the way. And as you read over the objectives here, I'm just going to tell you a little bit about myself. My name is Blake Fagan. I'm a family physician. I've been practicing for 23 years, and I'm in Asheville, North Carolina, which is in the western part of the state, in the mountains. And how I got into use disorders, first it was opiate use disorder, now into stimulant use disorder, is that we are part of the Appalachian chain, and there's been a lot of opiate use disorder and problems like that in the Appalachians. I started seeing patients that had opiate use disorder and stabilizing them with a medication called buprenorphine, and then really found that stimulant use disorder, but particularly meth or methamphetamine use disorder, is just a huge problem. And so we're trying to address that as well. Just to get a sense, for any of y'all that are in the criminal justice system side of things, you know, I've gone out to very small rural sheriffs and their deputies and talked to them and like, hey, we've got buprenorphine. We can help you with your folks that have opiate use disorder. And they're very kind and they listen and they say, yeah, that would be really great. Thanks, doc. But our problem is meth. So hopefully I can give you a little bit of understanding of methamphetamine use disorder, and then we can talk about some of the therapies that work. The foreshadowing is that the behavioral health therapies work the best, and we don't have a great replacement medication, unfortunately. But then we'll also talk about stigma and bias and health equity, because the stigma and bias in all substance use disorders, but particularly in stimulant use disorder, is really a barrier to providing great care. So we're going to start off with the epidemiology and the trends. There's really four big buckets for stimulant use disorder. Again, what I'm seeing mainly is methamphetamine use disorder, and it goes by names like meth and crystal and ice. I am still seeing cocaine use disorder as well, and you can see all the names there as well. But then there is a misuse of the prescription stimulants. Usually they break out into two categories of Ritalin and Adderall, but they have lots of other names there that you can see. And then finally, there's a product out there, the MDMA. It's the rave drug, or people talk about it as ecstasy or Molly. So those are the four big categories: methamphetamine, cocaine, prescription stimulants, and then MDMA. But a lot of the talk is going to be centered on two of them, methamphetamine and cocaine use disorder. So just to get a sense, there actually is some very limited therapeutic use for cocaine that's still used in the medical field. I am not using that. It's very limited use. Anesthesiologists use it occasionally, that kind of thing. But what it does is it blocks dopamine reuptake. So I'm going to end up talking throughout this talk about dopamine. And I just want to give you a sense. Dopamine is a neurotransmitter that's in your brain, and dopamine is why you live. So it's why you get up in the morning, go to work, make money, eat, sleep, have sex, the whole shoot and match. It's all about dopamine and stimulating dopamine in your brain. And you can imagine when you see this, it says cocaine, blocks dopamine reuptake. But then you move over to the methamphetamine, and not only does it block the reuptake, meaning the dopamine stays in the brain, in the synapses in the brain longer, but it also increases dopamine release. So when you talk to people that have a stimulant use disorder, and they're like, yeah, cocaine, I use that occasionally, or I had a problem with that. But the first time that I did meth, or the first time I did crystal, I was, quote, hooked, or I was in the chute, and I just not been able to shake it. It's because it is so much more powerful in the brain than even cocaine. So in the United States, the latest data that I am able to compile is from 2018. There's about 1 million people that have a methamphetamine use disorder, and then almost 2 million that misuse methamphetamines. About 1 million people have a cocaine use disorder, and about 5.5 million misuse it. So they can use it occasionally, recreationally, but aren't they haven't entered into their use disorder, or the old term for that is they're not a quote addicted to it. But we're trying to use new terminology that they don't have a cocaine use disorder. And then there's about 500,000 people that are that have a stimulant use disorder that's from prescriptions. After they first start taking it and misusing it, about 5 million, and they move into their use disorder, they're oftentimes crushing it up, snorting it, that kind of thing. And the trends are kind of bottomed out or ebbed around 2010, and then they've just been skyrocketing since then. So the rate of misuse of methamphetamines has been going up and up and up. And then we're seeing a lot of overdoses. And as I said, I was first on the opiate use disorder side of things, and then I started hearing, wow, people are dying from cocaine and from meth. And I thought, gosh, how is that happening? They must just be having a heart attack or what have you. But in and of itself, the medication can cause deaths. And then they also are finding that it's being cut with fentanyl. And so even if the patient is, or the person that you're seeing, the client, is not wanting to have polysubstance use, although a lot of this is polysubstance use, they sometimes don't actually know what they're purchasing and what's in the drug that they're using. So get a sense in Kansas, here's some of the numbers that you can review, but really I'm going to talk about the lower right-hand column, which talks about psychostimulants, and it's the blue bars. And what I want you to hear is between 2018 and 2019, the number of deaths from psychostimulants nearly doubled, and then the following year went up again. And men are dying at twice the rate for women. There's a lot of speculation. We don't have really good solid data as to why that is happening, but just know that of the deaths that are out there, men are dying at twice the rate of women in Kansas. And then you may know this, but as stimulant use disorder has been on the rise, we've seen more of the overdoses. Still, the #1 overdose death out there is from fentanyl. And I should pause and say, really, it's rare if somebody overdoses that they only have one drug in their system. If someone were to draw their blood, it's polysubstance use. And then stimulant use disorder, I wish it were I wish it were THC. People that take a whole bunch of THC kind of sit down, and people that take a whole bunch of stimulants like meth become very aggressive. We'll talk about this a little bit more, but they tend to interact with the criminal justice system even more because of the feelings and the symptoms that they're having, unfortunately. And then it's a huge cost burden. There's a medical side or a hospital cost, and then there's a cost to the system. It's very expensive, as you may know, but it's very expensive to arrest somebody, put them in jail, get them in front of a judge, sending them on to prison. It's in the billions of dollars. So nationally, seeing the same trends that you're seeing in Kansas, same trends that we're seeing here in North Carolina, where I'm from, is that stimulant use disorder deaths, although they're not rivaling opiate use disorder, are on the rise. And a big chunk of it is psychostimulants with opioids. The biggest one is fentanyl again, but there also is just deaths in and of themselves from psychostimulants. Again, cocaine, methamphetamine. So what was happening? Well, back in the 1990s, methamphetamine was kind of a cottage industry. People were manufacturing this in their homes or trailers or apartments, and they could make small batches. They were making small batches. They needed Sudafed, so they were going into pharmacies, and Sudafed at the time was over the counter, and they were just clearing them out. And then there was a bunch of laws that were starting to be passed where Sudafed was then behind the counter, and you could only give out one box per person, which helped to stifle that those meth labs that were happening in the United States. But then it's really dramatically changed. So this is a doc that has been working in this space a lot, and this is his quote. I just want to give it to you. It's way different from the meth that they were using 20 years ago. It's like drinking Mountain Bull, and now they're injecting Red Bull. And this is kind of into the Walter White, if I may say that, theme, that it's much more powerful, and it's being manufactured in labs and factories. Some of it is from China, but mainly coming from Mexico and being imported across the border. There's a large distribution that's happening, and it's moved through all 50 states. It used to be, I could say 5 years ago, hey, there's a lot of stimulant use disorder and meth use in the West, but it really is everywhere, including in Kansas, as you know, and including out here in North Carolina. And again, I want to keep saying they are cutting it with all kinds of stuff. And when I say they're cutting it with opioids or fentanyl, it's not just fentanyl. It seems like every couple months they're coming up with a new opioid that's been manufactured in the lab that's even more potent than the last one, such as this one here that I can't even pronounce the name. So moving on to the definitions and the pathophysiology, which means how is the methamphetamine affecting a person. So first, just pause and move back to substance use disorder, and you can think of it yourself, but what substance in the United States kills the most people? So think about that for a second. You can throw it in the chat if you want, but it is tobacco. So 400,000 deaths every year from tobacco. What's number 2? And it's alcohol use disorder. And then number 3 is opiate use disorder. Number 4 is stimulants. So going again to the big overarching thing, substance use disorder, what is it? It's defined as a chronic relapsing brain disease that's characterized by compulsive drug seeking and use despite harmful consequences. This is how I explain it. Hey, you keep doing something over and over again despite harm to yourself and or your family unit. If you're doing that, you're doing something over and over again despite harm to yourself and your family unit, then you have a use disorder. And when it says DSM-5, that's the Psychiatry Association of the United States is trying to define it. They've had 5 iterations. So there was a DSM-4, now there's a DSM-5. But what they're doing is they're kind of breaking up into 11 different things when they're talking about substance use disorder. So that loss of control, you're unable to cut down, you continue to have cravings, and you spend an enormous amount of time in the hunter-gatherer mode. You are, as one of my patients said, I said, what was it like when you were using? And they said, well, from the time I wake up until I go to bed, all I thought about was how to get my drug and how to get my money to get my drug. Well, that's that loss of control side. And then the more you use, you do build up a tolerance. And then if you stop using the drug, usually within 24 hours, sometimes even sooner, 12 hours or so, you start to go into withdrawal and it feels terrible. And then there's consequences out there. So you're running into the criminal justice system. You're going to jail. You're having to go in front of a judge. You're having medical problems. Let's say from your injection drug use, you now have hepatitis C. Just to tell you, it's an explosion out there of that virus that's affecting the liver. And the main reason for it is injection drug use. In Western North Carolina, in the last 5 years, 700% increase in the amount of hepatitis C that we're seeing from injection drug use. Main two drugs are opioids, but it's mainly fentanyl and then meth. Just getting yourself into dangerous situations. So, and this is a PET scan of the brain and a healthy brain on the left, showing how dopamine works and some of the precursors to dopamine or things that dump in to turn dopamine on, like norepinephrine. And then with methamphetamine use on the right, and then when you stop the methamphetamine use, you're just not getting your normal release of dopamine. So it's not when you stop methamphetamine that you then, after several hours, let's say 24 hours, that you go back to normal. You actually go below normal and you feel worse than normal. And we'll talk more about that.
Dr. Fagan,
Yeah.
we do have a question in the chat. Someone's asking if you can elaborate on the withdrawal symptoms from stimulants.
Yeah, so I have a slide coming up on that. Thank you for the question. But as you withdraw from it, you start to feel really depressed and down. So it's kind of the opposite of what they feel on the way up. On the way up, they can stay up all night. They don't feel like they have to eat. They get a grandiose sense of self, those kind of things. And then as they start to come down, like I said, it's this blase, this depressed kind of feeling. If they've been taking it for a long time, and actually they get sexual dysfunction. One of the big reasons that the men that I see say that they continue to use is it's not, I'm going back to my normal sexual fun. When they do use, they feel a heightened sense of sexual function and pleasure. But then when they stop using, they're like, I can't even have sex. And so I'm just giving you some of the symptoms, but we'll get to that slide. So thanks for that question. Okay, dopamine, again, it's why we live. We're chasing dopamine, whether you believe it or not. Yesterday morning, I woke up, I went for a run before work. I have to do a whole lot of things. It's cold out here. It was 37 degrees. I have to put a lamp on so I don't get hit by the cars. Why am I doing that? Well, it makes me feel good. I feel like I'm doing something for myself, maybe, but I get a good sense of it. And that's dopamine. It's dumping into my brain. So let's think about this. Think of your dopamine as having a base. Well, and that number is 40. It doesn't matter what the units are. Let's just pick this number. It's 40. That's what your normal dopamine in your brain is. And then think about the best day of your life. So you have the best meal, the best dessert, the best sex, and you can get to about 80. And that's the best day, right? That's your best day ever. So then when you take heroin, you can be up at 200, 400, 600. Again, remembering your base is 40, your best day ever that you can get to is maybe 80. And so now you can say, I can see how people, when they take heroin, they're like, that is the best I ever felt. And then they start chasing that, right? THC, it can get you up there around 200, maybe 100, a little bit more. But then methamphetamine, you are up at 1,000. And so when someone says, when I took meth for the first time, it was like the best I've ever felt, but it was like nirvana. It was like heaven. It was awesome. You don't understand unless you've used it, how awesome I felt. I really believe them. This is the data that's out there. So another way of looking at it is this. Again, remember, best day ever is 40. Best day ever is 80. Base is 40. You take methadone in normal doses. This is a medicine that we use to stabilize people's brains that have an opiate use disorder, and take it in normal doses, and you can get to that 40, maybe up to 80. But if you take too much of it, you can approach maybe 200. Nicotine, It bumps dopamine. That's one of the reasons that people say that my cigarettes are so addictive, they say, or they've entered into a tobacco use disorder. Look at that, you can be 200. Cocaine, you can be about 300. But again, look at this, methamphetamine, 1,000 or more on that release of the dopamine. That helps us to understand a little bit more of how much power this drug has over people, right? So now think about using over and over again. And when you do use over and over again, let's pick meth, then you start to down-regulate your normal amount of dopamine in your brain. So your brain keeps seeing 1,000, 1,000, 1,000. So instead of squirting enough out there to just stay at 40, it down-regulates those receptors. It down-regulates the normal use. So then when you withdraw the methamphetamine, they start feeling 20 every day. And 20, it feels like depression. So then knowing that they now have used, and they're like, they finally, something huge has happened in their life. They've interacted with the medical community because they ended up with hepatitis C or HIV, or they got an infection on their heart valves called endocarditis, or they interacted with the criminal justice system and they went to jail. Let's say they just got out and they're like, man, I never want to do that again. I'm really scared. But they feel bad. They have a lack of motivation. They have fatigue, but it's only all the time while they're awake. They have trouble concentrating. So they keep getting written up at work, or maybe even let go from work because they're not doing their job, the same job that maybe they could be doing before they were using meth daily. Trouble concentrating. And so then you can imagine how this leads to behaviors that are stigmatizing. One of those behaviors is they start using meth again, and they try at the beginning. I swear these are the stories I hear, and I truly believe them. Hey, I needed a little bit so that I could concentrate and get through my shift at work. And so I was just going to use a little, but as you know, they can't stop at just a little, and then they build up and they're taking a lot. And then they again interact with the medical community if they overamp. We're going to talk about that in a second. Or they interact with the criminal justice system because they're, again, are hunting for that drug or hunting for their money to get that drug. So they really go into survival mode in their brain stem, or what I call the lizard part of your brain. It just keeps telling them, get that drug, get that drug. Okay, so how does substance use begin? And it's not like people that have no trauma in their life are walking down the street and they're like, today I think I'm going to inject heroin, or today I think I'm going to smoke meth. It's much more complicated than that. Many people have grown up in a household where they saw drug use. Many people have grown up in a household where they experienced trauma, or they had high ACE scores, adverse childhood experiences. Maybe you've heard about this. Maybe it's been in this talk today, but if not, I really encourage you to look up ACEs. But it's very correlated that as your ACE score goes up, the chance that you, if you experience a drug, that you'll then move into a use disorder is extremely high. So again, those are things like, I had a parent in my life and then they left because of death or divorce, or they went to jail. I saw drug use in my home. I was beaten. I was sexually abused. These, you keep adding to your ACE scores. And then when you do interact with a drug, even just once, you are more likely to enter into a use disorder, unfortunately. So signs and symptoms, back to the question we got around stimulant use disorder. So short term, remember, you're going from 20 as base, or 40 as baseline, and you go to 1,000. So increased happiness and energy. Wow, that's the best I've ever felt. I got so much done at work. I cleaned my house twice, those kind of things. Improved attention, increased sexual desire. And you can read about this, like people that use meth and go on a quote bender and use meth for 2 or 3 days straight. Not only can they stay up for 3 days straight, but they can have sex over and over and over again. And then when you withdraw that drug, not only are they back to baseline, but they're below that, meaning they have reduced sexual function, and they remember what that was like and want to go back to it. They get this opening of their airways and this feeling of grandiosity, like I can do anything and I feel like Superman. They don't have to eat, but it also can increase your heart rate and your blood pressure. Long term, though, you take it over and over again. Remember, it down regulates your normal dopamine in your system, so you have reduced sexual function, chronic exhaustion, but also you can have seizures, you can have a stroke, you can have a heart attack. And these are some of the things that we'll see when they interact with the medical community. But the biggest one that I see on why people return to use, even though they want to do everything for themselves in their family unit, I don't want to ever go back to that drug, is that persistent depression, a persistent anxiety, and they want to go back and use and feel normal. So what is overamping? Maybe you've never heard of this term. I sure hadn't until about 3 years ago when I started moving into trying to help people with stimulant use disorder. But the first thing I heard is like, oh, well, overamping, that only happens to people that have been using for a long time and then they use too much. And I just want to let you know that's the myth. The fact is, overamping is absolutely unpredictable. It can happen at any time. It can happen with the first time you use methamphetamine or cocaine, any of the stimulants. It can happen if you've used too much for too long, but also you can use for a while, stop for a while, and then that first time you go back to it. So it really is unpredictable. It's not based on the amount that you use. And what is overamping is that the person uses and then has nausea, vomiting, they have chest pain, they get a high temperature, a fever, they start sweating profusely, they have this racing heart, and they can have really high blood pressure. It can lead to that heart attack and stroke even. They'll grind their teeth. Maybe you've heard of that specifically with MDMA or Molly or ecstasy that you hear about at raves, that people will grind their teeth, but this can happen with meth as well. They can feel short of breath. But then on the psychological side of things is that they get this extreme anxiety. They can get hallucinations, they can get paranoia, and they can get super aggressive. And again, this is then unfortunately how some people end up interacting with the criminal justice system. So that's overamping, and those are some of the signs and symptoms of using and then using too much, or just using a normal or a small amount, at least the patient thinks so, and then they overamp. All right. We're now moving into treatment for stimulant use disorder, and there's behavioral health treatments and there's pharmacologic treatments. Pharmacologic means medications that we can give. Unlike other use disorders, there's no good medications to replace this. So I'm going to back up again and remember what we talked about. Substance use disorder. The number one substance use disorder out there is tobacco use disorder. Kills 400,000 people a year. Through heart attacks, stroke, COPD, lung cancer, those kind of things, right? But we have a replacement medication for that. We can give people nicotine patches. We can give people nicotine gum for their urges when they have a nicotine urge. But we also have medications like bupropion or Wellbutrin that can help them to quit. Alcohol use disorder, there's 3 FDA-approved medications to try to help people. Opioid use disorder, we have methadone, buprenorphine, people call it also Suboxone, and naltrexone. But in the stimulant sphere, unfortunately, we don't have good drugs. Am I going to show you the ones that have a little bit of data, but not great data? Yeah, I'm going to show you that. But I just want to emphasize the things that have been proven to be helpful to help people with stimulant use disorder to reduce the amount of stimulant use disorder they're doing. So let's just pick meth again, reduce the amount of meth that they're doing. Or actually extinguish it, like so stop using, is all behavioral health motivated and generated. And then this is the problem with the 5 behavioral health modalities I'm about ready to show you. They are expensive and time consuming. So you don't just go and talk to a behavioral health person for 5 minutes and then you're like, wow, my meth use disorder is cured. No, it's a series of meeting with somebody and going through, again, I'll show you the 5 different things that have been shown to be helpful. And so you have to have a patient that's motivated and wants to do that, you have to have a patient that has an insurance that will pay for it. And these are really, really hard things to land, both of those. So here we go. Motivational interviewing has been shown to be helpful to reduce and to even stop stimulant use disorder. And it kind of goes like this, is you say, hey, you're using meth every day. And they're like, yeah. And I'm like, man, I'm really sorry that's happening. I wish it were different. So I'm empathizing with them. I'm doing some reflective listening if they tell me about their story, about how they got here. And then I say, well, hey, do you have any goals with your meth use? And they're like, yeah, I want to stop, or I want this to be the last time that I go to jail, or I want to get my kids out of foster care. And I'm like, great. So I write that down, and I keep, every time I see that patient, emphasizing, hey, remember your goal? Your goal was that you wanted to stop so that you can get your kids back out of foster care. And they're like, yeah, I remember that. And then you say, well, what barriers do you see between what you're doing now and getting to the goal of getting your kids out of foster care? And then that's the motivational interviewing. If you can get a client or a patient to start talking to you about, let's say, barriers or ways that they themselves need to solve their problems to get to their goal, whatever that goal is, then you're winning. Motivational interviewing is winning in that regard. So contingency management. This is fairly good data, actually some of the best data around stimulant use disorder, especially in meth and cocaine, about getting people to reduce their use and even stop. But this is a really charged words and how this works. So if you're saying like, what do you mean? I'm going to show you in just a second. So what you do is you have some kind of a positive motivation typically to get somebody to do what you want them to do. And sometimes it's around money or gift cards, and sometimes it's around privileges, like in prison or jail, or if you were in a detox facility. Let's say you were in there for 90 days and you're like, hey, I want to go outside. And you're like, okay, well, you have to do X or Y. And if you do X or Y, then you'll get some privileges. Does that make sense? But somehow there's a positive privileges. There's also can be negative or punitive. Just the data says it doesn't work as well. So let's just go back to, I'm an outpatient family doc, so I'm seeing somebody and I want them to extinguish or greatly reduce their methamphetamine use, because I don't want them to die. I also don't want them to get hepatitis C that costs the system $40,000 to $80,000 to cure it. I don't want them to get HIV. That can be over $1 million over someone's lifetime to take care of that chronic disease. There's no current cure. So I really don't want those things to happen. I don't want them to die. I want them to get to their goals. Hey, I want to get a job. I want to get my kids out of foster care. Awesome. I want to do that. And so then I set them up and I say, you know, if you'll come in and see me, you'll get a gift card to the local grocery store. And then after a while, I say, now, you know, we're not going to reward that. But if your urine drug screen next week doesn't have any meth in it, then you'll get the gift card. And you see how I kind of ramp that up. And there is really good data that if you give privileges or gift cards or cash, that this works. But you can see that there's on the political side of things, there's a group of folks out there that say, I don't like that, giving somebody something that they should just stop on their own. But I want you to pause again and remember, or this is what I believe, and I want you to remember that you at least heard it from me. I believe that methamphetamine use disorder is a chronic relapsing disease. Methamphetamine changes the brain. And if the person could stop, they would, and they can't. And so we need to find other ways to try to help them. Cognitive behavioral therapy is meeting with a behavioral therapist, and they try to give them coping skills. Hey, when do you use methamphetamine? Well, I do it when my brother-in-law, who's a truck driver, comes into town. Well, how often does that happen? Once a week. What are you going to do the next time he comes into town? I don't know. And then you say, you reflect back, do you think you'll use with him? Yeah. All right. So we have to give you new coping skills so that when he comes in town, don't meet him in your home or his home. Maybe you meet him out. Maybe you don't meet and you just talk on the phone. Maybe you go for a walk or something like that. There's something called a Matress Model. It's built on behavioral health and meeting with that therapist. But then actually adding a lot of other things like relapse prevention and family, trying to bring the family in, so family therapy and family dynamics. And the last one, this community reinforcement model, it's, I would say, the more difficult one to do, but it's the whole enchilada. You're not only trying to help them with their family relationships, you're not only trying to help them with coping skills so that they'll do better with their drug use, but you're trying to get them to get a job or get vocational guidance so that they can get new skills to get even a better job. You're trying to take care of all of it. This is expensive though. All right, moving on to the treatment modalities that had to do with medications. I want to say again, we don't have great medicines out there, but we can use agonist medications to replace the stimulant like meth. We can get an agonist in there like a prescription stimulant. You can do antagonists and you can do things that reduce cravings. The first one is dextroamphetamine. Another name for that for the providers out there is Adderall. And it's been shown with cocaine to have a modicum of help. But we've tried it with meth use disorder. It doesn't work great. There's anecdotally, I can tell you that some patients get on Adderall or this dextroamphetamine and they stop their methamphetamine use and it works for them. But overall, if we had better data and that really showed that this works, man, we would be using this as a replacement medicine or an agonist. Modafinil has other names like Provigil and Nuvigil. This was a medication that's supposed to help with narcolepsy. So it's, again, a stimulant. So you're trying to replace a stimulant with another one. It's been shown in cocaine use disorder to help, maybe a little bit. But there's been 2 trials that show it helps and 2 trials that showed there was no difference. So it's just really not great data. Topiramate, the medication can be used for both cocaine and methamphetamine, and it was shown to be helpful with some cocaine use disorder and reducing that use. But again, not great data. Mirtazapine, I have used this with several of my patients for methamphetamine use disorder. And I think one of the reasons is it also can be used for anxiety and depression. I think as a lot of people try to come off methamphetamine, I want to emphasize again, they get a lot of the ennui or the blahs or depression, honestly. And this is a medication that can help with depression. So I've used it in that regard, that I feel like I'm kind of doubling up. And I have a use with this medication over time and feel comfortable with it. I know the side effects and how it may be able to help somebody. So I feel comfortable and I've used this. Not great data though, again. Now, trexone is a medication that was found to be helpful with alcohol use disorder, and it works for that. And then was found to be helpful for opiate use disorder, and it works for that. And so then they tried it for methamphetamine use, and it's like, some studies haven't shown any help. Some studies have shown a little bit of help. But then the final one is one where they did show a little bit of good data going in the right direction. You combine the naltrexone that I just talked about on the last slide with bupropion, which is Wellbutrin. And those two together, we finally have a study that shows that it helped with methamphetamine use. But it really was around 11% of people reduced their methamphetamine use. And just to get a sense, if you have somebody with opiate use disorder and you put them on methadone or Suboxone, 50% of people. So 50% of people will lock into your program, do everything that you ask of them. So 11% sounds not so great, but 11% is better than 0. There's problems with this in that it's hard to get insurances to pay for these medications. The naltrexone that was in the study is an injection, and if you don't have insurance, can be up to $1,100 a month. So, all right, I think there was something in the chat. Anybody want to? fire up and tell me what's in the chat. I can see that there is something, but I can't see what it is.
Yes, Dr. Fagan. So the question was, contingency management's effectiveness seems to be evidence that there is, in fact, choice involved with substance use, right? Is that consistent with describing SUD as a brain disease?
So yes, so substance use disorder, and let's just again pick meth use disorder or cocaine. I really do believe that it changes the brain, not in everyone. So there are people that experiment with these drugs and are able to experiment once or for a short amount of time and get away from it. But for a lot of people, it changes the brain. And unfortunately, for some people, it can be permanent brain changes, or it can change the brain for a long time, and it'll take years for the brain to, quote, repair itself. So then finding something like contingency management, which gives somebody kind of a motivation, or if I can say it, we don't know for sure, but it seems like gives them some dopamine in their brain. Hey, if I do X, if I stop using meth, when I show up next time, I'm going to get a gift card or cash or more privileges. And you see how that can stimulate the dopamine in the brain and get people to be moving in the right direction as well. Is there another question?
We had a couple of substance specific questions. I don't know if you want to take those now or at the end.
Yeah, sounds great. Go ahead.
Okay, so the first question was, structurally, is the endpoint meth produced by P2P different than the meth produced from ephedrine or pseudoephedrine?
Yeah, and sorry, I'm not a biochemist, but yes, it's much more potent, and it gets to the same endpoint that people are selling it as blue or meth or crystal, is my understanding. But it is because of the manufacture, the beginning products are different. During the manufacturing process, you end up with much more potent meth, where I'm totally speculating now, but the meth of the 1990s, you were nowhere close to hitting 1,000 or 1,200 on the dopamine scale that I showed you earlier. And now with the new potent meth, it's really high, and it's because of those beginning inputs like the P2P. Yep.
Great, thank you. Just one more question, and I'm not sure if I'm going to pronounce this right, so I apologize if I don't. But there was a question in the chat about baclofen, if that sounds right, Baclofen.
Oh, yeah, baclofen.
Oh, thank you, baclofen, as an option for helping curb methamphetamine cravings and its effectiveness.
Yeah, so that is a medication that medical professionals use. It doesn't have great data, even less so than the studies that I showed you. I tried to pull that data, and this slide deck has been vetted by one of our pharmacists that is kind of our expert with substance use disorder, and we ended up leaving that off. But because so many of us have used baclofen over the years, it's a muscle relaxer, and particularly people use it with folks that have paraplegia or quadriplegia, and they're having a lot of spasm. And so we have a comfort with it that people tend to use that, and that's a go-to for a lot of people in the substance use space to try first. And hey, if it works and the person doesn't have side effects, most common side effects would be drowsiness, dry mouth, constipation. If they're not having those side effects or can live with it and it works, I'm all for it. So great question.
Great, thank you.
Mm-hmm. All right, so I'm going to move on to another section that if I can get anybody to think a little bit in this section and maybe approach patients that have substance use disorder, in our case, stimulant use disorder, just slightly differently, then I will say I'm winning with this next set of slides. But it really, our stigma and bias, including mine, hey, that's where I was. I tell people 7 years ago, if somebody would have came to me and said, hey, you should treat people that have substance use disorders, I'm like, I'm not doing that. If they would just quit doing the drugs they're doing, they would get better. I swear to God, that was what was going through my head. And then I had a patient that died of an overdose, and it changed my life. And I started reading all about this and getting into this space and trying to help folks. But it took me a long time to get here. So again, I'm just trying to open up the possibilities. So when addressing patients that have stimulant use disorder, substance use disorder in general, stimulant use disorder in specific, I want to let you know that almost all of the folks, if they've been in their stimulant use disorder for any length of time, have interacted with the medical community and been judged or put down or made to feel bad, or they've interacted with the criminal justice system and again made to feel bad. So if you can just spend a little time of be curious and non-judgmental, establish a relationship, and empower your patients, because they are very marginalized. So empower your patients. How do you do that? Well, this is how I do it. I see somebody new that has a meth use disorder, and I say, hey, tell me any part of your story you want to tell me about how you got here. You don't have to tell me anything. And I'm giving them back a little bit of the power. They tell me a little bit, and I go, I want to help you. Man, that feels good, right, for the patient. And then I say, we want to see you here in a non-judgmental way. If you ever feel like when you call in, or you're brought back by the nurse, or you're seen in the lab, or you see one of my partners and you feel like you're judged, would you tell me? That person's not going to get in trouble. It just might be a new person that we've hired, and they just don't know what we're trying to do here. And you see their head nodding, and they're like, you're giving them back a little bit of power, or you're empowering them to speak up if they're not feeling that they're being taken care of well. And I'm telling you, that's not happening in very many other places. And then constantly educating your staff about how addictive, for lack of a better word, but how this medication, these meds like meth, can really grab the brain and change the brain and develop into a use disorder that's a chronic relapsing disease. But you got to educate the folks that you're working with. And then we're trying to use new language. Language does stigmatize people. So, and I've already used some of the language that you're not supposed to out there, but instead of saying you are a drug abuser or you have drug abuse, is that we say, hey, you have a use disorder. And then naming a person. This is when you're checking this person out to someone else, hey, I have a patient or a person with substance use disorder, instead of saying I have a drug addict here in my office. And then when we're getting urines, we talk about how the urine drug screen is as expected or not as expected, instead of clean and dirty. And then we say it's a drug. What's your drug of use instead of your drug of choice? If you really get down to it, once they've been in their use disorder for any length of time, they're really not choosing that drug anymore. They fear withdrawal, so they keep using. And even when they get through withdrawal, the cravings are overwhelming, and that's why they're going back to that drug. They're really not choosing it. It changes the brain. It's a chronic relapsing disease. And then health equity. I really had to learn all this, and I'm still not perfect at it by any means. But the idea being, hey, you're at a baseball game. There's 3 boxes, and 2 out of the 3 kids can't watch the game. Equality is you give everybody a box. That's equal. But still, one kid that could watch the game is still watching the game, but from a better vantage point. One kid that couldn't watch the game is now watching, and then the other kid still can't see it. But equity would be, hey, give the one kid that needs it 2 boxes so that they can watch the game. And then even better, why don't we take the fence down so everybody can watch it? And then inclusion is nothing about me without me. In terms of the patients we're seeing, we should be including them in their care and when we're trying to set up systems to help them. There are disparities out there with stimulant use disorder. White people use stimulants more than Black people, but a disproportionate number of Black people die from stimulant use disorder. That's just the data, that's the facts. And deaths from cocaine use disorder disproportionately affect Black people. Again, that's just the data that's out there. And one study found that a greater number of white patients completed treatment for methamphetamine use disorder than Black patients. Why is that? Well, we don't know, but one of the thoughts is that the Black patients are feeling more stigma and bias when they're interacting with the medical community. We're not sure what all the reasons are. I'm sure it's multifactorial. So harm reduction strategies for people with stimulant use disorder. I really want to go over this. Seeing the patients and trying to connect them to care, or if you're the provider, being that provider that will treat the patient, that is harm reduction. But there's lots of other harm reduction out there. So trying to get the patient to use clean needles until they are ready to stop their injection meth use. That's great, because then it reduces the chance that they get HIV or Hep C or endocarditis, the infection of the heart valves. It's harm reduction for the patient, but also it's great for the system. Just think about it for a minute, but if you have to go in and do a surgery and replace a heart valve because it's been so damaged by injection drug use that it has to be replaced or the patient may die, how much do you think that will cost? And man, it's hard to get that number in the medical hospital system, but I can tell you, I finally landed it. It's between $200,000 and $300,000, and somebody is paying for that, right? As they're doing that, whether it's the hospital because the patient has no insurance, or it's the insurer or something, or we could give them clean needles, fresh needles at a needle access point for a couple months, and then that patient decides that they want to stop on their own and comes in to seek care, and those needles cost pennies compared to $200,000 to $300,000. Not everybody agrees with that. I hear that, but I'm just throwing it out there that is harm reduction. And connecting people to harm reduction services like needle access or getting them naloxone. They interact with folks that are seeing them in a curious and non-judgmental way. And the data is very clear that those folks then, when they finally hit their low point and they want help, because people at that needle access or the health department that's been giving them the naloxone or what have you, have been seeing them in a non-judgmental way and caring for them, they go to them and they say, I'm ready for care. And that's what we really want to happen. So there are good Samaritan laws out there. You have to find out in Kansas if you have them. In North Carolina, if you roll up on somebody and they've overdosed and you give them naloxone, you cannot be sued. And lots of states are coming out with that now. And again, any harm reduction is great. Anytime you can reduce the chance that somebody returns to use or overdoses, reducing that, I'm saying, is absolutely life-saving. So who should be carrying naloxone? And you're like, oh yeah, people that are prescribed opioids, particularly at really too high of doses, people that have an opiate use disorder, that makes sense. But I'm also telling you that anybody that has stimulant use disorder should be picking up naloxone, because so much of it now is cut with fentanyl and its derivatives. And again, going to syringe access, it's been shown, it's been proven to reduce substance use. It empowers patients to seek care and reduces transmission of infectious diseases. All right, we have about 6 minutes left. I want to pause here and ask our team to come back on and see if you all have any questions you'd like to put in the chat.
Thank you so much, Dr. Fagan. We do have a couple of other questions that came through. And again, forgive me if I mispronounce any of these medications, but there was a question about Vivitrol plus Wellbutrin and mirtazapine along with contingency management. What's the effectiveness of that?
Yeah, that's a great question. And if you have a patient that has insurance, again, remember the Vivitrol, the other name for that is naltrexone. It's the injection or IM naltrexone. It lasts for 30 days. If you don't have insurance, it's $1,100 or more. If you have insurance, they'll pay for it. Great. The Wellbutrin or bupropion is inexpensive. And the data was only on those two medications together, showing that 11% of people with meth use disorder extinguished or greatly reduced their use. But if the patient is willing to do contingency management or behavioral health or participate in motivational interviewing, yes, all modalities is what I would say. But if you're asking where's the data, there is not a randomized controlled trial of doing contingency management plus Vivitrol and Wellbutrin versus the Vivitrol and Wellbutrin arm by itself. So that's not out there. Same with mirtazapine.
Great, thank you. There was another question related to that combination and how it helps reduce meth use. There was a question, does it help reduce cravings, or how does it work exactly?
Yeah, we're not 100% sure, but the thought process is that it helps to reduce the cravings. That's right. And now that we're on that one, I also want to say why they chose this in the study. They must have had a reason, but the Vivitrol, the IM injection, which for alcohol use disorder and opiate use disorder is an injection once every 30 days. They were injecting it every 21 days. So every 3 weeks instead of every 4 weeks. So then you run up against another barrier that, or at least we have. So you have somebody and they have great insurance. And the insurance was like, yeah, we'll pay for that Vivitrol and the Wellbutrin. Yeah, we'll pay for that. It's relatively inexpensive. But then if you really follow that study, 21 days later, you try to give another shot and of the Vivitrol, and then the insurance rejects it because they're like, no, that's a every 30-day drug. So the study, although again, it showed some benefit, it's very hard to apply it in the primary care patients that I'm seeing.
Great, thank you. Just one more question that's come through that I've seen is a question about gabapentin. The question was, what's the word on gabapentin? But I'm assuming the real question is, what's its effectiveness?
Yeah, so gabapentin for stimulant use disorder, we don't have great data out there. Do we use it sometimes? Yes, because the person also has, let's say, chronic neuropathy or neuropathic pain, like they have really bad burning in their feet that's caused by their diabetes or what have you. And so we're hoping that we'll double up there, but there isn't great data around stimulant use disorder and gabapentin. But again, I want you to hear, do I use gabapentin? Yes, I try, I try everything. Do I use gabapentin over in the side of things where someone has a opioid use disorder? Is at times, yes. But the place that I use it the most in a use disorder is with alcohol use disorder, and I've had some decent luck with it. Just not there with stimulants, unfortunately.
Thank you, Dr. Fagan. Those are all the questions I have seen come through the chat. I'll pause here and give just a few more seconds in case anybody thought of something that they wanted to ask. We have another question. Yes, go ahead, Lori.
There's one on the platform.
Excellent. Yes. So the question is, what are your thoughts on using, forgive me again, Doexpen for substance or stimulant use disorder? Yeah,
I think the word may be doxepin. It's a
thank you.
It's a yeah, thank you. It's a tricyclic, and I don't have the data on that. It wasn't in the poll when we tried to find the medicines that had the best data. But again, this is what I'd say about doxepin. I've used it to help people with trouble sleeping. I've used it to help people that have depression. There's various other reasons to use it. But if you find that someone has a use disorder, a meth or a stimulant use disorder, and they're having trouble with depression, and you want to try it and it works, like, hey, my depression's better, and I noticed that I have less cravings and I'm not using my meth anymore, you're winning, right? As long as you just talk to them about the side effects, which are all the anticholinergic that you probably know about if you're asking that question, and you document it like, hey, I told the person that they could have these side effects, and we try it. Anecdotally, that sounds great to try that medication. It's just, unfortunately, we don't have great data around it that I'm aware of.
Great, thank you. Last question here. Why are some treatment facilities not using methadone, in your opinion?
Yeah, so this is switching over to a opiate use disorder question. So just for everybody to switch gears for a second. The number one way that we treat opiate use disorder in the United States is still detox and abstinence. People go into a 14-day, 28-day, or 90-day inpatient stay. And you just have to know that while they're in there, let's just pick the 90-day. Let's say they don't use any opioids. They go through withdrawal in 3 to 5 days. That's done. And they don't use any opioids for 90 days and they leave that facility. 90% of people will return to use in 6 months to a year, and it's because of the cravings. The opioids cause brain changes, and some people, they're just overwhelming. And so 10% of people that go through that will successfully go into long-term recovery. That's wonderful. I'm an all of the above person, so that 10% is great. But if you use methadone or buprenorphine, 50% of people at 6 months to a year will have methadone or buprenorphine in your urine drug screen, but no other opioids. So when we're talking about life or death, 50%, in my opinion, is better than 10%. So it's all about stigma and bias and education. To answer your question, we need to get more and more of those facilities to do that. And frankly, if more and more states that certify inpatient detox say you have to use the evidence-based medications, then they would do it. But in North Carolina, it's a big problem. There's still the majority of our inpatient facilities do not use methadone or buprenorphine for opiate use disorder.
Great, thank you. Thank you so much, Dr. Fagan. We are actually a minute over our time, so we will end there. But thank you so much, Dr. Fagan, for your time today and your expertise. A great way to end the day for sure. We appreciate you so much.
Thanks so much. Take care, everyone.
All right, just a couple of housekeeping notes to